Hi, everyone. My name is Dr. Shika Jain. I am a GI medical oncologist at the University of Illinois Cancer Center. Thank you so much for understanding that I'm sadly not able to be there with you all in person. I know there are several people who wanted to connect with me. So if you do want to reach out to me, please feel free to shoot me an email after this, and I'd be happy to set up some time to talk with you. I'm also going to try to limit the time that I'm speaking so that we have enough time for Q&A at the end, and I will come on live for that. So I'll be talking to you today about colorectal cancer and ctDNA and the role that we are seeing of ctDNA in the colorectal cancer space. It's an exciting time for GI malignancies in the sense that we're able to utilize ctDNA in a variety of ways, including prognostication, prediction, and finding ways to really help it guide therapy. So I'm excited to be talking to you about this topic today. So disclosures, I am on some speaker bureaus and some advisory boards. None of these should have an impact on my talk today, though. So today we're going to start by talking a little bit about the history and background of ctDNA and talk about some of the trials that have been most impactful in the colorectal cancer space. We'll talk about future directions, and then we'll end with some information on how I utilize ctDNA in my clinical practice. So first, ctDNA has become an established biomarker of measurable or molecular residual disease, or MRD, in our colorectal cancer patients. So many of us have started using it in a variety of ways. And as I mentioned, we can use it to guide treatment in both the prognostication space as well as the prediction space, looking at how high a risk patients are for recurrence. So the hope is that we can start moving towards more personalized care where patients may be able to get less chemotherapy based on their minimal residual disease or ctDNA results. So some of the trials I'll be talking about today, I'm going to be talking about the BESPOKE trial. That was a colorectal cancer trial looking at ctDNA detection of minimal residual disease, and it was able to really showcase the fact that ctDNA can be a powerful prognostic and predictive tool, especially in patients with stage 2 and 3 colorectal cancer. So that's really important for our patients when we're trying to decide adjuvant therapy versus no adjuvant therapy versus length of time for adjuvant therapy. So we'll talk a little bit about the BESPOKE trial. The GALAXY trial looked at stage 2 to stage 4 colorectal cancer and patients, and they looked at the prognostic value and predictive capabilities of ctDNA, and it was analyzed in almost 3,000 patients. And what this study found was that a sustained ctDNA clearance significantly was associated with more than a 90% disease-free survival. So again, the GALAXY study was a pretty impactful trial as well, and we'll talk a little bit more about that one. The dynamic rectal cancer trial looked at it was a phase 2 trial looking at the use of ctDNA as an informed approach after surgery. The ctDNA informed approach to look at really adjuvant therapy and the benefits to adjuvant therapy after a patient had received neoadjuvant chemo-RT and surgery. And this study actually looked to see the impact on how many of these patients received chemo, and it actually reduced the rate of adjuvant chemotherapy. And then we'll talk a little bit about the COBRA trial. The COBRA trial actually failed to demonstrate a benefit in guiding adjuvant therapy selection, so it was a negative trial. So first, let's talk about BESPOKE. So the BESPOKE trial, to be eligible, you needed to be a stage 2 or 3 patient. You needed to have residual surgically resected FFPE tissue from an adeno-CA of the colon or rectum. You needed to have a good performance status. You needed to be clinically eligible to receive chemo. And you needed to be at least 18 years old, so an adult, and you needed to be able to provide consent. The endpoints the BESPOKE trial looked at was the impact on adjuvant treatment decisions, the rates of colorectal cancer recurrence while asymptomatic, and then secondary endpoint was looking at overall survival, patient satisfaction, physician utility, the rate of minimal residual disease clearance, and adjuvant treatment rates, as well as surgery rates for oligometastatic recurrence. So the BESPOKE trial enrolled over 1,700 patients with stage 2 and 3 CRC who had surgery and either started adjuvant therapy or were followed with observation. Of 623 patients, 280 had stage 2 colorectal cancer, 343 had stage 3, 93 had detectable MRD by ctDNA between 2 to 12 weeks post-surgery. So that's something I don't talk about too much today, but one of the challenges with many of these studies is when you're checking the ctDNA. There's concern for false positives and false negatives. Some people are often concerned if you check the ctDNA too close to the time of surgery, are we getting an accurate number, accurate report? There's also been concern that if you check it and it is positive, is it potentially that it could clear, or if it's negative, could it actually come back? So if you check it at 2 weeks, is it possible that there's too much kind of noise from the surgery and inflammation, and we end up with an inaccurate result? So what the BESPOKE trial found was that ctDNA positivity at any testing point for MRD was prognostic for inferior disease-free survival. So having a positive ctDNA basically was a negative for patients, and it showcased inferior disease-free survival in that population. Adjuvant chemotherapy did benefit patients who had a detectable MRD, but not for those who had an undetectable MRD. So again, this suggests that we may be able to potentially avoid adjuvant chemo in patients with a negative MRD in the future. ctDNA positivity during surveillance was prognostic of inferior disease-free survival, regardless of whether the patient received adjuvant chemo. So if the patient ever had a positive ctDNA, that was a poor prognosticating factor. And ctDNA positivity was predictive of the benefit of chemo. So basically, if a patient had a positive ctDNA, chemotherapy would be beneficial. If they had a negative ctDNA, it's unlikely that the chemo was going to be beneficial. And a positive ctDNA at any point was prognostic for a worse disease-free survival. ctDNA positive patients who were followed with observation were significantly more likely to have a recurrence. Sustained ctDNA clearance was associated with a superior disease-free survival compared with those who had a transient or no clearance at all. So again, if you have a negative ctDNA, if you're able to clear the ctDNA with adjuvant chemo, then you have an improved disease-free survival. And patients really seem to appreciate the use of ctDNA and the information that it helped in guiding their treatment plans. So looking at the prognostic benefit, the median disease-free survival was not reached in undetectable MRD cohort, so those with a negative ctDNA, and that was at approximately 16 months in the detectable MRD cohort. The 2-year disease-free survival was 92% for those who were ctDNA negative versus 30% for those who were positive, and that was statistically significant. Patients who were MRD positive or ctDNA positive who were treated with chemo had a median disease-free survival of almost 18 months versus 8 months for those who were ctDNA positive and were observed. And again, median disease-free survival was not reached in the undetectable MRD group. So there was definitely a benefit for adjuvant chemotherapy in the MRD positive group and not in the MRD negative group. This is a study that was presented by Dr. Kasi at GI ASCO this past January. So looking at these beautiful graphs here, you can see that over here on this graph, you're seeing MRD positive patients had a significant improvement in their disease-free survival if they received adjuvant chemo, as opposed to those who underwent observation. But for those who are negative, there really isn't much difference between the adjuvant chemotherapy group and the observation group. So again, another way that we can look at the benefit of getting a ctDNA to really determine if a patient's going to benefit from adjuvant chemotherapy. So what did the BESPOKE trial concluded? Despite receiving adjuvant chemo during surveillance, only 22% of the ctDNA positive patients were disease-free at 2 years, compared with 98% of the ctDNA negative group. So again, ctDNA negative or MRD negative patient populations will definitely have a more likely chance of having a longer disease-free survival. In the observation group, 13% of the ctDNA positive patients were disease-free at 2 years, while 97% of those who were ctDNA negative in the observation group were disease-free at 2 years. And 85% of patients with transient clearance had disease recurrence within 15 months. So the BESPOKE trial was really helpful for kind of helping us better determine and better describe the benefits of MRD and ctDNA testing when you're trying to figure out adjuvant therapy versus no adjuvant therapy, as well as having informed conversations with patients. The Galaxy trial looked at stage 2 to 4 resected colorectal cancer patients, and they were observed for up to 24 months after surgery. It was almost 3,000 patients who were in this study, and 38% received adjuvant chemo, and 62% were followed with observation. The primary endpoint was disease-free survival. So looking at these plots here, the disease-free survival by pathological stage in the post-op 4-week ctDNA positive population. So these are patients who had a ctDNA test 4 weeks after surgery. And if you look at the disease-free survival in this first graph here, high-risk state pathologic stage 2 patients. So these are the patients who got adjuvant chemo. These are the patients who did not get adjuvant chemo. And you can see with adjuvant chemo, the 6 months disease-free survival was 100%, 12 months, 88.9% for adjuvant chemo. Without adjuvant chemo, that dropped to 6 month disease-free survival, 53.8%, and 46.2% in the 12-month disease-free survival. Now looking at pathologic stage 3 patients, looking again, these graphs are pretty well separated. Patients who got adjuvant chemo, 89% were disease-free at 6 months, 68% at 12 months. And then those who did not get chemotherapy, 32% at 6 months, and 24% at 12 months. So again, this is really a pretty significant finding, showcasing the difference between patients with getting adjuvant chemotherapy, looking in the ctDNA positive population. And then looking at stage 4 patients, again, you can see a significant difference with adjuvant chemo versus without adjuvant chemotherapy, the difference in the patient's disease-free survival. So positive ctDNA was predictive of adjuvant chemotherapy benefit across all of the stages that were studied in this study. So now looking at disease-free survival by adjuvant chemo in the post-op 4-week ctDNA negative population. So this is looking at high-risk stage 2 through 3. And this was really interesting. You're seeing, overlap basically of these two graphs here, whether the patients got adjuvant chemo or not in the ctDNA negative population. You're seeing pretty comparable 6-month disease-free survivals and 12-month disease-free survivals. So 98.6 versus 97.5. 96.2 versus 94.7. So not really a significant difference between the ctDNA negative population and them getting chemo. So this would suggest that there's minimal, if any, benefit from giving adjuvant chemotherapy in this particular ctDNA negative population. So this trial concluded that the clearance of ctDNA, especially if it was sustained, significantly improved outcomes. And it also showed that transient clearance on chemo correlated with improved disease-free survival compared with patients without clearance, but the prognosis again remained poor. Post-op 4-week positive ctDNA testing was significantly associated with inferior disease-free survival. And if you were negative ctDNA at the 4-week mark, those patients did not derive significant benefit from adjuvant chemo in the high-risk stage 2 and 3 population. The 24-month disease-free survival was 86% for patients with negative ctDNA at 2 to 10 weeks after surgery, and only 28.9% for those with detectable ctDNA. So again, showing that there is a lot of ways that we can utilize ctDNA, whether it's determining prognosis, whether it's determining who will benefit from chemo. So a lot of utility to these tests. The receipt of adjuvant chemo for ctDNA positivity led to clearance in 66% of the patients. And for patients who had a sustained ctDNA clearance, the 24-month disease-free survival was 90% versus 2.3% for those with a transient clearance and 2.0% for those with no clearance. A return to positive status after a transient clearance happened within 18 months for 98% of the patients who became ctDNA positive again. So again, showing that sustained ctDNA clearance or ctDNA negative testing can show an improvement in highly significant improvement in disease-free survival. A greater than 50% reduction in ctDNA concentration at 6 months was associated with a 24-month disease-free survival of 51% versus 29% with less clearance. So again, showing even if the ctDNA doesn't completely clear, showing a significant reduction in the level of ctDNA can also improve disease-free survival. So now let's talk about the dynamic study. The dynamic rectal study looked at locally advanced rectal cancer, clinically stage T3 and 4 and node positive. These patients would have received preoperative chemo-RT. They would have had a surgery, TME surgery prior, a good performance status, no metastatic disease, and ctDNA analysis was done at week 4 and 7 post-op. And then they were stratified 2 to 1. Into either standard adjuvant treatment decisions at the clinician discretion or ctDNA informed management. So basically, if your ctDNA was positive, then you would get 4 months of adjuvant chemo. If your ctDNA was negative, plus you had a pathologic N0, then you'd be observed. If the ctDNA was negative, plus they had a positive nodal status, then it would be up to the clinician whether they gave chemotherapy or not. And the endpoints, the primary endpoint was proportion receiving adjuvant chemo, so looking to see which patients got chemo. Secondary endpoint, looking at the 3-year relapse-free survival, so looking at non-inferiority data. And then another secondary endpoint was overall survival and the ctDNA dynamics. So this was a really interesting study. It unfortunately, due to the pandemic, it did cease recruitment early and increase the adoption of total neoadjuvant therapy, since there has been a shift towards total neoadjuvant therapy in the rectal cancer population. So again, the purpose was utility of ctDNA and guiding adjuvant therapy. 75 patients received treatment of clinician's choice. 155 underwent ctDNA informed management. Chemo was given to those, again, who are ctDNA positive at week 4 and or 7 after surgery. ctDNA negative patients, they got no chemo if they were node negative, or clinician's choice if they were node positive, and 28% of the patients had a positive ctDNA. So looking at the recurrence-free survival, if you look at the top arm, that's standard management, and the purple is ctDNA informed management. Looking at a median follow-up of 36 months, the recurrence-free survival. Looking at this top graph, you can see there's a pretty significant space here. When you're looking at the 36-month mark, you're looking at 82% versus 74%. So again, it looks like that using a ctDNA informed approach may have some benefit. What they found was that the use of ctDNA to select patients for adjuvant chemo resulted in a reduction in chemotherapy use. Chemo given to 46% of the ctDNA arm, so 27% of ctDNA positive patients, 16% of ctDNA negative patients, versus 77% of the control arm. So again, it looks like we could potentially use ctDNA to decide who should and should not get chemotherapy. The 3-year relapse-free survival for ctDNA guided management and standard management was 76% and 82% respectively, but the sample size was too small to really effectively compare this outcome. The difference in 3-year recurrence rate was seen between ctDNA negative and ctDNA positive patients, 83% for patients who are ctDNA negative and 53% for those who are positive. For ctDNA positive patients, so remember all of those patients were treated with adjuvant chemo, they were twice as likely as the ctDNA negative patients to get a relapse in a distant site. The most common sites of relapse in the ctDNA negative population was the lung, and in the ctDNA positive population was the liver. But a caveat, again, I want to emphasize this was a small sample size, so it does preclude any major conclusions to be drawn about the non-inferiority of ctDNA-informed treatment plans versus standard management. So that's just something important to remember about this trial. Now let's talk briefly about the COBRA study. So this was the negative study I mentioned to you. So this was looking at resected stage 2A colon cancer for which the physician would decide chemotherapy versus active surveillance. So arm 1 was standard of care, active surveillance, and arm 2 was assay-directed therapy. So ctDNA was detected, they would get chemo. If it was not detected, then they'd have active surveillance. This is a randomized phase 2/3 trial, and it failed to show clinical utility in guiding adjuvant therapy. It was actually closed early for futility. They randomly assigned 635 patients with resected stage 2A colon cancer to active surveillance or assay-directed therapy. And again, these patients received chemo if they were ctDNA positive or surveillance if negative. And the primary endpoint was a rate of ctDNA clearance. Among the first 16 patients with ctDNA detected at baseline, 7 were randomly assigned to standard of care, which was surveillance, and 9 were randomly assigned to adjuvant chemo. And the rate of ctDNA clearance after 6 months was 43% versus 11%. But this particular study found that adjuvant chemo was not more successful in clearing ctDNA, or minimal residual disease. But I just want to mention with this that, again, this was a very small study, so we would need more data, and more studies are needed to look further into this. Let's talk briefly about ASCO 2024 that just happened. This is the one abstract I wanted to talk about today in relation to what was presented at ASCO. It's an update, 5-year results from the randomized dynamic trial, which I talked to you about earlier. So the dynamic trial, just to remind you, it's an adjuvant stage 2 colon cancer trial, multi-center randomized, and eligible patients had resected stage 2 colon cancer and were suitable for adjuvant chemo. They were randomly assigned 2-to-1 to ctDNA guided management, or standard management, and a ctDNA positive result at 4 or 7 weeks after surgery with a tumor-informed assay prompted adjuvant chemotherapy. And ctDNA negative patients were not treated. So again, treating all positive patients, positive patients were determined with a tumor-informed assay prompted adjuvant chemo. Those who were ctDNA negative were not treated. The previous results of dynamic, as I mentioned, showed that ctDNA guided approaches versus standard management in these stage 2 patients can reduce the utility and the use of adjuvant chemo without compromising the 2-year relapse-free survival. ctDNA positive at 4 or 7 weeks after surgery with a tumor-informed assay prompted adjuvant chemo. So the median follow-up time, we're looking at 59.6 months, and the 5-year overall survival for ctDNA negative T3 and T4 disease population were 96% and 90.6% respectively. The 5-year relapse-free survival for ctDNA clearance versus ctDNA persistence was 85.2% versus 20% respectively. So again, 5-year relapse-free survival for patients who at the end of treatment had ctDNA clearance was significantly better than those who did not have ctDNA clearance. 5-year overall survival was also significantly worse in those who were ctDNA positive and were treated versus those who were ctDNA negative and untreated. So 85.6% of the ctDNA positive patients was their overall survival, and 95.3% for ctDNA negative patients. So the interpretation of that is if a patient is ctDNA negative, they could have an even better overall survival with active surveillance, as compared to somebody who was ctDNA positive. Mature outcome data confirms the previous finding of non-inferiority of relapse-free survival with a ctDNA-guided approach to adjuvant chemo for stage 2 colon cancers. Again, for patients who are ctDNA positive, end of treatment ctDNA results did provide additional prognostic information, because those who did not clear their ctDNA had a worse prognosis. And this data really did support this role for ctDNA analysis, including serial sampling in the management of stage 2 colon cancer. So future directions, where are we heading with all of this? Well, there's the Erase CRC that's looking at circulating tumor DNA to affect the adjuvant or post-adjuvant treatment of patients with stage 3 and high-risk stage 2 resected colon cancer. This is a prospective open-label multi-center study, including 3 phase 2 trials enrolling ctDNA positive patients with radically resected stage 3 or high-risk stage 2. Patients that are ctDNA positive after surgery are going to be randomized 1-to-1 to 6 months of either FOLFOX or CAPOX versus FOLFOXIRI. And I'm excited to see what comes of that particular trial. I want to end, because I know we're getting short on time and I want to leave enough time for Q&A. I want to talk a little about clinically what I do when it comes to ctDNA. I use ctDNA to help guide decision-making in the adjuvant setting in certain scenarios. If a patient has a positive ctDNA, I'm more likely to do a longer amount of chemo, so 6 months versus 3 months of adjuvant chemo, for example. I know the IDEA trial really helped us identify that 3 months of chemotherapy was non-inferior and in some cases even superior to 6 months of adjuvant therapy. But I think because ctDNA wasn't incorporated into that trial, we need to really look at these patients and say, if you are ctDNA positive, what is the conversation we need to have with these patients about should we extend the length of the adjuvant chemo, because we have seen such an improvement in relapse-free survival and in some cases overall survival for patients whose ctDNA clears. I use negative ctDNA also to assess whether a patient may or may not need adjuvant chemo. I'm still not at the point where negative ctDNA will get me to not give somebody 3 months of adjuvant chemo after curative intent surgery for a colon cancer patient. I would be interested to see if more trials come out supporting that, and maybe that will be practice changing in the future. I also discuss with my patients the utility of using ctDNA as a complement to the other surveillance testing that I continue, including tumor markers and imaging, because I think they're important to utilize together. So in conclusion, ctDNA is a powerful prognosticator for recurrence in CRC. The challenge is the ideal time is still being studied. We're not really sure what the best time point to get that first ctDNA is after surgery, and then how often we should be checking the ctDNA. I typically do it every 3 months because when my patients are on active surveillance, that's how often I get their tumor markers and their imaging, especially in the first year. But I think that's something that's yet to be determined, what the best utility is for the time in between those tests. And then talking about when you're 2, 3, 4, 5+ years out, what is the benefit of continuing to check ctDNA and how long should we be continuing to check it? I think will be an interesting information as we garner more data. So obviously more data and more studies are needed in order for us to really better personalize the care that we're giving to our patients utilizing ctDNA informed approaches. So the question that I have for all of you, for you to answer is, which of the following statements about the use of circulating tumor DNA in early stage colon cancer is true? A, ctDNA is only useful for detecting METs in late stage colon cancer. B, ctDNA can help predict recurrence and guide adjuvant therapy decisions in early stage colon cancer. C, ctDNA is ineffective in monitoring treatment response in colon cancer patients. And D, ctDNA levels remain constant regardless of tumor burden or treatment. I'm going to pause. I'm going to let you all think. I'm going to say how many, you're going to have to raise your hand because Dr. Wynn's going to check to see who's raising their hand because I'm not there. How many of you think it's A? How many of you think it's B? How many of you think it's C? How many of you think it's D? And how many of you didn't answer? All right, so the answer is B. ctDNA can help predict recurrence and guide adjuvant therapy decisions in early stage colon cancer. When I come live to do Q&A, I'm going to ask Dr. Wynn how many people raised their hands. And if you didn't, I'm going to call you out, just FYI. All right, so I just want to thank you for allowing me to speak today and share some of this data with you. I have to include a photograph of some of the people who make my life so wonderful professionally and personally. My family's on there. A bunch of the people from UIC are on there. I want to thank my UIC colleagues who are just awesome and I love working with. I love coming to work every day and working with all of you. And down in the bottom corner, you can see my parents because they are my biggest support system. And then up in the left corner, you see my husband and my kids because I love them and I wouldn't be able to do anything without the support of my family. So with that, I say thank you. I'm going to stop sharing and I will be here to answer questions.